Welcome to Life, insight and experiences into love, relationships, and fertility, with a focus on enjoying life and moving forward. Today, we'll be speaking about miscarriage with Dr. Lora Shahine. Welcome to Life, Love, Insight, Fertility Experiences. I'm thrilled to be here today with Dr. Lora Shahine. She is the perfect person to have this conversation about pregnancy loss. And I had been wanting to find somebody who would be wonderful to talk about miscarriage because it's so prevalent. And she is an author, she's a professor, it's her specialty. She is a big contributor to ASRM and Resolve. And so thank you so much for being here today.
Oh, thank you so much for having me. What a wonderful opportunity.
Oh, God, thanks. And thank you for getting up so early because you're on the West Coast. So that's special.
No problem.
So the reason why I wanted to talk about pregnancy loss is because it's something that so many people go through. And I don't think people necessarily realize how prevalent it is until they start this journey. And just to start to frame it a little bit, from somebody with your background would be fabulous.
Oh, thank you. Well, you touched on some really important points just in your introduction, just how common miscarriage is and how important it is, how it's defined. And so, and because that sort of dictates how common it is as well. I mean, really the statistic you'll hear the most is 1 in 4 pregnancies will end in miscarriage. And that's really talking about clinically recognized miscarriages, miscarriages that get to the point where you can see something on ultrasound or test, tissue. It's called a clinical miscarriage, a clinical pregnancy loss. But if you include biochemical miscarriages, which can be a positive pregnancy test followed by a late or heavy period, it can be up to 70% of fertilized eggs actually end in miscarriage. So it's quite common.
Yeah, I'm so happy you're able to put that number out there. Not that people have to experience this, but that you can put that number out there because very often people don't know that. And I think the more that we could say it and the more we could get that information out there, the better it is.
Well, because people, that's not the narrative. The narrative is you spend your whole life contracepting or being told how easy it is to conceive. And when you're ready to conceive, you can stop whatever birth control method you might be using, and it's going to happen right away. And that as soon as you see a positive pregnancy test, in the movies, then, quick flash scene forward to delivering and,
right.
Labor and delivery. The narrative is not miscarriage. So when it happens and people don't talk about it, it's very shocking. People feel very alone and isolated and they feel that it's abnormal. Yeah. And it's actually quite a normal process that doesn't take away the grief and it doesn't take away the lost time and the sadness. But it's actually such a common occurrence. It's actually a natural process. And we need to know that because it doesn't mean that we don't investigate it. It doesn't mean that we don't ask questions, but I think people feel so isolated that it adds to the emotional toll.
Absolutely. I couldn't agree with you more on that. I mean, I have some people who I've worked with who write about it and they need to talk about it so that people realize the pain in the morning and the grief. Even if they go on to get pregnant, that kind of stays with them. I think it's really important that we mention that you're doing a second edition of your book that's coming out in October, specifically because of the changing guidelines that are going on right now in defining this through ASRM.
Absolutely. I'd love to talk about that. Yeah. So traditionally, before 2013, the definition of recurrent miscarriage was 3 consecutive clinically recognized pregnancies that were lost before viability. And so there's so much in that, what I just said. It's like one sentence, but it says so much. So 3.
And does it give a time frame for it? I mean, that's a huge statement alone.
Correct. No, there wasn't a time frame, but it said 3. Okay. It said consecutive. So somebody who had a miscarriage, then had a baby, then had another miscarriage, they wouldn't say that that's recurrent because someone had a baby. And then the clinically recognized pregnancy loss, that means it's, again, far enough along that you could see something on ultrasound or test tissue. And that's typically about 6.5 weeks pregnant. So it excluded biochemical miscarriages. In 2013, the American Society of Reproductive Medicine, or ASRM, which is the real professional society for reproductive endocrinologists that specialize in first trimester miscarriage, that's like me, changed the definition, clarified it, and said recurrent miscarriage is, it's okay to start an evaluation if someone has 2 clinically recognized miscarriages. So they dropped the number from 3 to 2, and they took out the word consecutive. And they still clarified that it needed to be far enough along to be considered a clinical pregnancy loss. They did not include biochemical miscarriages in the need to do an evaluation. And they did clarify that if someone's doing studies, that they needed to still have 3, but in the field where you're working with patients and you're doing an evaluation, it's okay to start an evaluation with 2. And so that was a big change, and that was 7 years ago.
That's really huge, because I am not a doctor. I do typically encourage people after 1 to ask and to just become curious about why that happened.
Yeah.
It's a big change to go from 2 to 3.
Yeah. And so for my first edition of my book, Not Broken, I talk about that's the definition, and, that was published in 2017. But this March in 2020, ASRM updated their definition of infertility and recurrent miscarriage. And they define recurrent miscarriage as a disease separate from infertility with 2 pregnancy losses. And they took out the word clinical, and they just said a very generic statement after that, just that every pregnancy loss should be evaluated and discussed, And so removing the word clinical miscarriage, although it leaves it open, it doesn't say every biochemical miscarriage should be evaluated. It just allows for more interpretation and room. And it is important. There are studies that show that women with multiple biochemical miscarriages, do have a higher risk of another miscarriage. They do have sort of the same findings that women with later miscarriages can have, like anatomic issues, hormonal issues, and really do deserve to have that evaluation. And that's important. And I think it really stems too from the European Society of Human Reproduction and Embryology, ESHRE. They came out with this definition in 2017. So it took 3 years for ASRM to update, but I'm just so glad that they did, and it really instigated a second edition of the book because I wanted to clarify.
Yeah, no, I'm so glad that they did also. I think it's very important. Also from the emotional toll it takes, because many women, even just if they have 1 pregnancy loss, regardless of if it's very early or very late, can have a profound impact. And so what I find is with the people who I'm working with, whether there's a loss after 4 weeks or a loss after 8 or 12 or even 26, the impact can be pretty strong in their ability to kind of enjoy a next pregnancy. Be able to take a deep breath during a next pregnancy until they either hit the mark of where that loss was, and in some cases until the baby is born.
Absolutely. Yeah. Patients have taught me that sort of innocent joy of a positive pregnancy test is taken away after a miscarriage.
It's a wonderful way to put it. And there's a lot of grieving that goes on, and a lot of sadness that can't be enjoyed, sometimes anger. And so just to be able to get at that and start the grief at that point is even helpful to be able to talk about it, I find.
Yeah, I just hope that it allows for more fulfilling discussions between patients and doctors. I do want to really emphasize that even if you do testing and evaluation for recurrent miscarriage, most of the time you don't find an issue in the people that are getting pregnant, because the issue is in the embryo. The most common cause of miscarriage is a chromosome imbalance or a genetic issue within the embryo. It's unique to that pregnancy, and it doesn't mean that it would happen again. So
Right.
most people will go on without significant testing or intervention to have a healthy baby and family without significant intervention. I really want to emphasize that. Um, I I hope that this relaxing of the definition will allow people to have fulfilling conversations and get those discussions from doctors rather than the dismissive, oh, well, we're not going to do testing until you've had 3.
Yeah, I hope so too, because it's a lot about empowering the patient,
Mm-hmm.
be able to have that dialogue and bring that up. Because I find that sometimes the doctors want to talk about it, and sometimes they want to make it into a very light situation, because there is what you had said before, approximately 70%, which is huge. So if we know approximately 70%, then, but really there's only something that we have to investigate in 1 out of 8. That's a huge disparity, a huge difference. So,
Exactly.
so that's important to look at. It doesn't take away from the feelings that people feel when they do have a miscarriage, though. What do we do with people who have recurrent pregnancy loss? Is there a standard protocol or a way to talk to people about that?
Absolutely. But I will say that professional medical societies differ in their recommendations. And so patients and providers can get confused, and there it is a really frustrating situation. There are certain tests that are very much agreed upon. So if someone has had recurrent miscarriage, it's important to do a uterine cavity evaluation to make sure there's not an issue for an anatomic issue causing miscarriage. It's important to do karyotypes, which is a blood test looking for what's something called a balanced translocation in both of the people that are getting pregnant. It's a genetic issue that's very rare, but it's a recommended test to do. There's some hormonal screening to do, like thyroid, prolactin screening for diabetes, certain immune issues, blood clotting issues. But there are things that professional societies agree upon, and then there's so much other room for people to do different tests. It's a very controversial field,
Why would it be so controversial?
Well, because guidelines change, but a lot of doctors don't keep up with the guidelines. It's true. Part of the reason is, if you don't, just like anything in medicine, if you don't focus on something, it's not like you're reading all of the studies that come out. If you aren't going to the professional medical societies and keep up to date, most obstetricians are really focusing on other parts of their practice, delivering babies, or wellness checkups and pap smears and things. And most of them aren't really focused on recurrent miscarriage. And so they might be practicing like they learned how to practice 20 years ago.
Yeah, we need them to go to your classes.
Well, it's hard. You go into medicine to help people, and a lot of medicine can be black and white. If someone has high blood pressure, you can counsel them about lifestyle modifications or give them a prescription to make their blood pressure look better. You can fix it. With recurrent miscarriage, because there's not always a clear-cut answer, it's very gray. It's uncomfortable for a lot of physicians and healthcare providers, because they want to give that answer. And it's very emotional. The patients are vulnerable. They want answers. And so there's a lot of room for frustration.
Yeah, I can understand that on the part of the physician and the provider, and then how to address it. And they want the patient to be optimistic about moving forward if it's one loss. And it's
Mm-hmm.
now that they can investigate, it's even better. Just from my own perspective, I I don't really like sweeping those feelings under the rug because eventually they come back. And they come back at times that you don't necessarily want them to. So you want to use, I like to use the word just to grieve it or just to recognize the loss as what it was or what it is, so that when you do move forward, it just makes it a little bit easier. And so for some people, that just means talking about it for a couple of minutes. And for other people, it means talking about it for longer. And that's okay.
Absolutely.
And I find with the partners as well, lots of times they're at a loss and they feel like they don't necessarily have the right to grieve, kind of quote unquote, because it's not their body and they're not going through it, but they are going through it. They're just going through a different path of it.
Yeah.
Yes.
Yeah. The emotional piece of this, I think, is as important as the testing and the treatment piece. I feel like the studies do show that with people with miscarriage, if you follow them without any intervention, over 90-95% of them, if they keep trying, they'll eventually have their family. It might, and there's follow-up for 5 years, and that's a long time to wait, but absolutely people will
So
be successful.
it's within 5 years, not within two.
I mean, within 2 years, it might be closer to like, 50-60%, but if you wait longer, it will, if you're getting pregnant, eventually it will happen. It's just the waiting that's so hard.
It's very hard. It really is. So when we look at this in first trimester, because
Hmm.
that is where I think the majority of the loss comes in. Is that accurate in first trimester?
Yes. Yes,
So if somebody is having recurrent pregnancy loss in the first trimester, you would recommend these tests be taken?
I do. Yes. Later loss, like in the second and third trimester, that's out of my area of expertise, and you're getting into less um, genetic issues. Most chromosome issues or genetic issues, the pregnancy will stop developing in the first trimester. Later losses are sometimes associated with um, uh, cervical incompetence, infection, um, some blood clotting disorders, and then oftentimes it's unexplained,
That
and
word,
that's so hard.
right? With all of this, the word unexplained is so hard.
Absolutely. We need more research. That's another huge issue, is we need more research in all of women's health and reproduction, but specifically miscarriage.
So early term loss, early term miscarriage, even those that we can't necessarily capture because it is your period's 2 weeks late, and then you get a heavy period. How would that be studied, or could it even be looked at?
Honestly, we can't study like tissue, like we can't, because it's so early along. It's we can't do genetic testing or chromosomal testing because there's really nothing to test. It's like very small number of cells. um, but you know what we have learned with these home pregnancy tests that are so accurate, and they're able to pick up on the pregnancy hormone, even days before a missed period, or within a
Unbelievable.
week.
I mean, they haven't
Unbelievable.
been that long when you think about it in the scheme of things, and they have only gotten more and more sensitive and accurate.
Right. And without the explanation to women of how common this is and
Yes.
how inefficient reproduction is. And so it's increasing our stress and our worry that there's something wrong with our body, without explaining just how many embryos are abnormal.
Yeah.
Like we know that even when they were developing the home pregnancy test, one of the biggest arguments against putting it in the drugstore and having people be able to buy it themselves is biochemical miscarriages happen so often, 2, 3, 4 times a year, and women aren't going to be able to handle that emotionally. There's a big pushback. But
Yeah.
we've learned just how common it is. And the other way that we've learned is the ability to do genetic testing on embryos.
Mhm.
So with IVF and the use of that technology and testing just so many embryos over the last 20 years, we've realized, my goodness, when someone's 40 years old, 80 to 90% of the embryos that that couple creates are going to be abnormal.
Wow.
You know, the chance of miscarriage at 40 years old is 50%. You have a positive pregnancy test, there's a 50% chance it doesn't continue. And that's normal, but the message isn't out. And it doesn't feel normal, and that doesn't mean that it's okay. But when doctors say, oh, just try again, or if someone's young, oh, you're young, you have plenty of time, they are actually scientifically and medically correct. But it feels dismissive if you're the patient, if that's all you hear and they don't explain the rest of the story and just how common it is for embryos to be abnormal.
I think that's like such a great word to use with people too. Like, don't you find they have a sigh of relief when you say it's normal?
Yes, I try to explain. This doesn't mean that the feelings aren't validated, but your body is actually doing what it's supposed to do.
Yeah.
You know, yeah, it's just it doesn't take it away, but it just validates a lot of those feelings. I mean, you do such a good job in your podcast just talking about the emotional aspect of fertility and miscarriage, and people really have described it as, you know, PTSD, you know, and trauma.
I had one person who unfortunately had like a 27-week loss. And
I'm so sorry.
oh, it's heartbreaking for her, heartbreaking for her husband. It was, I get tears in my eyes just thinking about it. And even now when they have a child, it still comes back, you know, because there's so many different ways to go through that. And it's very hard. It really is, because it's a huge loss. So it doesn't take away from loving the child that you have in front of you, but you still have to recognize what you've been through. Yeah, I do find people though that after first trimester have a profound impact also. But more so with reaching that point again. So if it's at 10 weeks, they have to get over that 10-week hump.
Yeah. And it's I mean, just with a positive pregnancy test, what we do is we start thinking, oh, when's the due date?
Yes.
You know, is it a boy or a girl? You know, you have these visions of what your family is going to be like. And so when that's taken away, it's a grieving, it's loss, it's a lost time, it's a loss of this vision of what you expected to happen.
Yes, and that's really that's what I find so wonderful about support groups or Instagram posts, or you know, the work that you do online. It allows people to realize that they're not alone, and some people might find that expression overused, but it's an important thing to recognize. And some people are a little shy to join a support group. They prefer not to talk about it, but there's a relief that comes with it, realizing that this is normal and you're not alone, and it's not fair that you had to go through it, but you did, and maybe that just gives you a different perspective and allows you to be a little stronger. And the testing that could go on now that you described, it doesn't sound incredibly invasive.
True. Yeah, blood tests, and then, you know, it's for the uterine cavity evaluation, usually it's something like a saline sonogram or a hysterosalpingogram, where it is like a pelvic ultrasound or a pelvic procedure. That I would say that's the most invasive test.
Yeah, but compared to what people go through, it doesn't sound as if it's a painful test.
Correct.
But no residual there. So all of this said, I suppose that with miscarriage or recurrent pregnancy loss, it falls into very often unexplained infertility, which is very frustrating to grapple with and very hard to grapple with. The difference in some of this, though, is most of it does not lead to infertility. Most of it leads to trying to figure out if there's something we could do to support the female as they move forward in the next pregnancy, and if there is even anything that needs to be done.
Right. I think you know, the the way I see most of my patients is the first visit is really a lot of talking and a lot of education and a lot of understanding what their history is. And then it's testing. And then at the follow-up visit, and even before we do the testing, I say, listen, there's a majority of the time we don't find an answer, and you need to know that. I need to prepare you for that, because the issue is usually in the embryo, and we're testing the people that are getting pregnant. And at the follow-up visit, I sort of say, listen, if we don't find something that we can fix, like a thyroid issue we can give a medication for, or a fibroid that we can remove, really the options are two. Number one is keep trying. And number two is honestly IVF with chromosomal screening of the embryos, to decrease the risk of another chromosomally abnormal embryo implanting. And those are such extremes, like really invasive, expensive, time-consuming IVF versus trying again. And so I try to emphasize that no matter, neither one is perfect. And I try to emphasize that no matter what, no matter how you get pregnant next time, even if it's with trying naturally, one of the best things that I can do is to give supportive care. And so there are studies that show that women who do get supportive care with their obstetricians or their reproductive endocrinologist, which is me, which means, early blood tests, early ultrasounds, an on-call provider, whether it's a nurse or a doctor that they can call if they have spotting, that supportive care and just knowing that their questions are going to get answered results in a higher live birth rate. Nobody can explain that, nobody can
That's amazing.
give a scientific answer. But I think that's one of the things that we help people the most with, is that a reproductive endocrinologist is so used to helping people through that first trimester, because people get pregnant with IVF or with an IUI, and, we help them through the first trimester, and then they go to their obstetrician, right? So my office and my team is just so used to people who are very invested in the pregnancy, very nervous through the first trimester. And so, but a lot of people can't see an RE, there aren't very many in the country, and a lot of them might not focus on recurrent miscarriage. So, what I'd love for people who are listening to this podcast to take away from, or who read my book, is, I want you to be an advocate for your care. I want you to understand what the tests are, to have a fulfilling conversation. It doesn't mean that you have to have every test done under the sun, but ask for what you need. Hey, when I get pregnant next time, can I do blood tests? Like, how am I going to get my questions answered? Be vulnerable. Tell that provider, I am going to be so scared until I get past 8 weeks. Like, how am I going to get support from your team? And, maybe you can connect with a nurse in that office that, she might not be in the office every single day, but that if Sally's in the office, she can talk to you because you had spotting last night. It's just...
I just love that. I really do. I tend to give people, well, before we were working on Zoom, I tend to give everybody who comes into my office a journal and a pen. And
Absolutely.
so I love that takeaway that you just gave. And maybe if you don't mind, can I just ask one more question before we end?
Yes.
The spotting, because the spotting doesn't necessarily mean something awful is happening.
Correct. Yes. Very common to have spotting in the first trimester. It does not necessarily mean miscarriage.
It doesn't. Could that be almost anything, the spotting? Or...
Absolutely. There's so many changes that happen in the first trimester, hormonal changes, the uterus is expanding, the placenta is implanting. We very often never know exactly why someone's spotting, but I imagine you think about that the uterus is so vascular, right? And if the placenta is implanting and it might hit a little vessel as it's implanting, I can imagine that there would be a little bit of bleeding. So I can't take away that fear, that, oh my gosh, here we go again. It's going to be another miscarriage because this is exactly what happened before. But I can say, listen, you can come in the office tomorrow. We can take a look with an ultrasound if it's far enough along to see anything. We can do another blood test just to kind of give you that feedback. And, I have definitely had people who are just like, I know that I've had a miscarriage. Like, this happened to me before. I just know it. I saw it, and they come in and everything is fine on the ultrasound, so you just can't assume. You just have to find that provider and that office is going to hold your hand through the process.
Wait, no, I think that's great. And your takeaways are wonderful, really, just to be your own advocate and to find that supportive person, and let them know what you need and not be afraid to talk about it. This is all normal. So if somebody wants to get a hold of you, how would they do that?
I'm very active on social media, and I do get a lot of requests on Instagram for patients who would love to connect with me and be my patient. And I'm happy to do second opinion consults, but I'm always very honest with people that the type of care for miscarriage care is not something that you can really do over the phone and across the country and, in a different city, because it's ongoing. Any provider can do the tests that I outline in my book or on my blog. And it's much more about the ongoing care and the being an advocate for your own care wherever you are. Just connecting with me and me being the doctor is not a quick fix, because I just can't do it across the country.
That's great. And they're reaching out to you because of everything that you have to offer on your Instagram with a huge element of fun, but which is wonderful. It's a great way. And I could see why people are reaching out to you. So if somebody does want to reach out to you who is local, who could possibly treat you or with a question for a second opinion, they could do so on one of the social media platforms. And if anybody has any questions or any comments, please feel free to reach out to me at lorimetz.net. Thank you.
Thank you.